Good morning, all. Welcome to Pediatric Grand Rounds today. Today our speaker is Dr. David Musick. Dr. David Musick joined the faculty and administration of Virginia Tech Carilion School of Medicine in July of 2013 and worked in medical education since 1992. He is the Senior Dean for Faculty Affairs and he's responsible for oversight of faculty affairs and faculty development. A professor in the Department of Internal Medicine, he has extensive teaching experience in a variety of formats, including small group facilitation, didactics, workshop, case-based learning, and online content delivery. His research interests include assessment and program evaluation, social and cultural aspects of medicine, medical professionalism, leadership, spirituality in medicine, and faculty well-being. He is very busy, it would seem. Please join me in welcoming Dr. David Musick.
Well, good morning. Thank you so much. It's really a privilege and an honor to be asked to speak at Pediatrics Grand Rounds. I will tell you, when I first came in 2013 to run one of the very first opportunities I had to give a presentation was at Pediatrics Grand Rounds, and I don't even remember what it was about at this point, but I remember being so impressed with the fact that I think you all were really pioneers in this idea of taking Grand Rounds and shooting it out to people in the region and beyond, and including people from other locations. So that was really impressive, and I remember that. So it's really an honor to participate in your Grand Rounds, and I'm grateful for the opportunity to say a few words about one of my favorite topics, spirituality in medicine. It's something that I've had more of an academic interest in, I suppose, as compared to folks who are clinicians who would probably look at this a little bit differently, but we'll talk about that as we move along. And it's just really great to be here, so I thank you for the opportunity. So here's our objectives today. We're going to introduce the role of spirituality in healthcare, as also the idea of how to take a spiritual history. Some of you may be hearing that phrase for the first time. Some of you may be very familiar with it. The idea of taking a spiritual history from a patient, and then provide a very brief overview on the research about patient spirituality and its potential impact on health and illness outcomes. That last bullet point, I want to emphasize the word brief, because there is so much literature on the research aspects of this that I was telling Biddy I could come back and do a part 2 maybe at some point just about the research part, because that area of inquiry has really exploded over the last 20 to 25 years. So we're just going to barely touch on that today. So by way of background, as you think about this, the idea that our health is not solely based on the body, but also what Plato referred to as the soul, is not a completely new idea. This has been around for quite a while, actually. And Plato says, as you cannot cure the body without the soul. And fast forwarding just a little bit to more recently, the famous hematologist, Dr. Cabot, talks about this in terms of how he apparently in his practice frequently was consulted about what he called the deepest problems in metaphysics and religion, not as speculation, but as an integral part of what humans experience. So this is not a brand new idea. There have been lots and lots of surveys done about this, in terms of clinicians as well as patients. Here's one from February of 1988, so notice the date, that's almost 40 years old, right? And at that point in time, it was found that 65% of people who were polled on this issue felt that it would be good for their physicians to talk with them about their spiritual beliefs. And yet only 10% say that a physician had actually done that. That's an older poll, but there have been a number of different surveys since then that have had very consistent findings along these lines. There's something about this issue that patients feel is very important to speak with about their physicians sometimes. So we'll talk a little bit more about that. This was a study done at Duke Hospital in 1998, so a little bit more recently, and they asked 337 consecutive admitted patients to Duke's hospital to self-rate what they call their religious coping, and how often do you use religion to cope with the circumstances in your life. And as you can see, a little bit north of 2/3 said either it was the most important factor or certainly something that figured in a large way, in terms of their ability to cope with their circumstances. By the way, I should have said this earlier. I practiced these slides yesterday and I got through all of them in about 35 or 40 minutes, which means there's lots of time for people to ask questions, to stop me, to say, wait a minute, can you talk about that some more? I want you to participate if you so desire. So please feel free to do that, and then we'll have time at the end for questions as well. So with that background, what role should spirituality play in the provision of healthcare? And if spirituality is an important component of healthcare, how should we approach it? How do we do that? Well, there's a large and burgeoning literature on this. It really got its start about 30 years ago. So we're going to touch on the high points today, and hopefully I'll whet your appetite if you're interested in this to explore it a little bit more on your own. It's probably important, though, that we define our terms a little bit. So I've used already both the terms spirituality and religion. Are they the same? No, I don't really think they are. Spirituality is generally viewed in the literature as whatever it is that gives a person a sense of ultimate meaning or purpose in their life. So that sometimes, or most often, may reference a deity of some type, but not necessarily so. And there are also very important differences in terms of this phenomenon depending on where you are, regional or geographic differences. So for example, we are in the southeastern United States. This area of the country tends to be a lot more religious, maybe than certain other areas. You may have already encountered this with some of your patients. And so you might find that this is more of a prominent issue here as opposed to other parts of the country, or maybe in our country compared to other countries. But spirituality is the more general term. Now, religion is often viewed as sort of a subset of spirituality. And it's typically described as sort of a working out of your spirituality or giving behavioral expression to spirituality. Religion is very focused on certain behaviors. So, for example, attendance at meetings of some type with those who share your spiritual views or your religious views, participating in things like prayer or meditation, reading some type of sacred literature. These are all parts of religion, and they're also behaviors that one can observe, right? Whereas spirituality is a little more esoteric, and it's a little more in the mind. But I think it's an important distinction to make, because I think there are certain people who would probably say they are spiritual, but not particularly religious. And I suppose you could also flip it the other way. You could probably say there are some people who are religious without being particularly spiritual. I don't know. But I would typically hear a lot from folks who say, I'm a very spiritual person, but I don't really participate in any particular religious practices. So it's an important distinction to make. Now, if you want a little more detail, then I'm not going to bother to read this, but this came from the Handbook of Religion and Health, which is about 20 years old now, written by a gentleman named Dr. Harold Koenig, who is a psychiatrist and also a board-certified internist at Duke. And Harold Koenig is one of the big names in this field. If you Google his name, you'll find a ton of publications on the topic of religion or spirituality and healthcare. And so he defines it this way: spirituality being the personal quest for understanding answers to the ultimate questions about life. Whereas religion is more of an organized system of beliefs, practices, rituals, or symbols. Typically, spirituality is a little more individual, whereas religion is oftentimes a little more group-focused. If that makes sense. So I like Dr. Koenig's distinction there. This area has not been without controversy. This is a quote from a few years ago from the Journal of Medicine and Philosophy, and representing the viewpoint of some people who work in the area of bioethics. And you can read the quote: bioethicists, humanities scholars, and social scientists who study religion, and to some clinicians as well, the discourse of the present-day spirituality and medicine movement is both intriguing and troubling. So it's interesting, but it's also a bit troubling in this particular point of view. Why that might be the case? Well, it certainly would have an impact on the physician-patient relationship. There's also the concern about proselytizing. We know that's a fancy word for trying to convert someone else to your particular religious point of view. And there's concern about that. Certainly lack of training for physicians. This is not really the most prominent thing that you'll learn about while you're in medical school or residency, perhaps. Maybe this, in fact, may be your first time for thinking about this. So it's definitely not something that a lot of physicians feel like they've had good training on. There are certain negative aspects of religion. We could probably all think of examples of that, but that would certainly be a concern as well. So let me stop here and ask you a question, and I'll depend on you, Megan, to monitor if there's any responses in the chat. Have you ever had your patients or any of your patients' family members talk with you about this topic? Anybody? Okay, see several hands going up. All right, good. It does come up, certainly in certain well-defined situations. Not so much every day, but in certain well-defined situations. Here's a couple of case examples. So this is a 15-year-old female who was admitted to an inpatient unit after an overdose of Ambien tablets. She adamantly tells everyone that she was not trying to commit suicide, but that she was just taking more pills because she was not able to sleep. Her mother was not able to wake her up, so she called EMS and they transported her to the hospital. She states to the physician, quote, "I would never kill myself. Everyone knows that's a straight ticket to hell, right?" You see any spirituality in that statement, any cue perhaps there that indicates something about her belief system? Here's a different case of an adult, more in the psychiatry setting. Mr. J is involuntarily committed to your unit because of severe depression and not been taking care of himself. He acknowledges being depressed, but he states that he has strong faith in God and that God will heal him of his depression without the need for any medication. Therefore, he refuses all psychiatric medications, telling the physician that they violate his religious beliefs. However, he does continue to take his medicines for diabetes and hypertension. So that's an interesting twist, right? I mean, it's interesting to think about what his thought process is and how you might react to that as his clinician. In terms of medical education, in 1993, this is fairly well established, there were 3 medical schools in the United States that had any material about this at all in the curriculum. I was at the University of Kentucky in 1992, and there was a private foundation, now known as the Templeton Foundation, but it was called something else back then, and they put out some curricular development grants, and they said, we'd like medical schools to apply for these, and I applied and got one of the first ones at the University of Kentucky years ago. So I was fortunate in that respect. By 2023, over 100 schools now do this, and it may be even higher than that. Most of these efforts center around health outcomes, patient coping skills, or perhaps end-of-life care. So it has actually grown a great deal in terms of medical education since the early 1990s. I will tell you that here at our medical school, Virginia Tech Carilion, I'm not that familiar. We have some students here. You could probably tell us whether this is mentioned in your early training, like when you're going through clinical skills with Dr. Schmidt-Dalton. Is this built into part of what you learn about? Okay.
Mm-hmm.
Yep.
It's part of the questions that we ask when we're taking the
Okay.
history. So asking if they have any spiritual or religious beliefs that they find important or impactful in their care. So
Nice.
it's part of what we're taught to ask about, but I haven't really had any experience doing it actually in
Okay.
clinical practice yet.
Okay, cool. Yeah. Yeah, thank you for telling us about that. And I'm glad to know that. I thought that was probably the case, but I just wanted to confirm that. I started, back when the pandemic hit here, I started a online elective because when that hit, we were scrambling for how to handle the whole pandemic situation. So I started a completely online elective that 3rd or 4th year students can take called Spirituality and Medicine. And I've had probably a dozen or so students take that. Got four students scheduled to take it this year. Completely online, so you kind of work at your own pace. There's a lot of reading. There's some review of some video modules that are offered by Duke through Duke Center. And then there are several papers that you have to write. And the feedback I've gotten so far has been pretty positive. The students who have taken it seem to really like doing it. You also have the option when you do that elective to spend either a full day or 2 half days with a hospital chaplain. Now that's optional because it was obviously optional during the pandemic. Toyed with the idea of making that mandatory, but so far I haven't done that. But I really think it would be valuable. And the students, about half the students who have taken the elective had done that, have gone ahead and spent time with the chaplain, and they always say, wow, what a positive experience that was. So, did you have a thought in the back?
Yeah.
Okay, sorry.
Scratching my head.
Okay. So as a result, you can, if you dive into the literature, you'll see a lot of different papers out there now. One of the early ones dated 2004, there in the middle. But you can see over the years 2004, 2014, 2019, and then this article in JAMA that came out in 2022, Spirituality and Serious Illness and Health, has really gotten a lot of attention. It's an exceptionally well-written article. If you don't want to read anything else about this, I would encourage you to take a look at that one, because it really does a nice job of sort of summarizing the field and talking about its applicability, particularly in situations where there are serious challenges to the patient's health. And finally, still thinking about the sort of the background of this, the Joint Commission, which is the accrediting body for hospitals, this is the group that comes in and makes sure that the hospital is operating at a very high standard. They added something about this in January of 2004, so about 20 years ago. And you can see in the box toward the lower left there, the Joint Commission requires organizations to include a spiritual assessment as part of the overall assessment of the patient to determine how the patient's spiritual outlook can affect his or her care, treatment, and services. So this is now a requirement. When they come around to check up on the hospital's accreditation, they will dive into this. And this has really led to even more emphasis on the importance of chaplains being part of the healthcare team and making sure that they're integrated into the care process. So why is this important? Well, it's a response to patient interest. We talked about how there are many, many surveys that have been done on this topic that show that patients are fairly interested, at least some of the time, in talking about these matters with their physician. There's growing evidence that supporting patients' spiritual practice may improve health outcomes in a variety of conditions. We'll look at that in a little more detail in a few minutes. And then there are three broad areas of discussion concerning this interface between clinical medicine and spirituality or religion. We could probably spend a 2-hour seminar or more on each one of those 3 bullet points there. But these are the general topics of discussion when one thinks about these things. I think you could also say that this certainly is a part of holistic healthcare and a holistic orientation. The focus on the therapeutic relationship is a key feature of care, as we know. It's very common to speak of the biopsychosocial model of care, but now more and more people are saying, let's talk about the biopsychosocial spiritual model of care. That word's getting pretty long, so it doesn't roll off the tongue, does it? The biopsychosocial spiritual model of care. And then if you're in psychiatry, if you had exposure to psychiatry, they talk a lot about the strengths model. And that means when somebody is facing some challenges, what are the strengths that they already have that they can bring to bear on helping with that problem? And certainly a patient's spirituality, sense of spirituality or religious beliefs could be one of those strengths that could be tapped into in that respect. It's interesting when you look at psychiatry, they have done almost a complete turn in terms of how they view this. When I first started working on this in the early 90s, I think it's fair to say that there was not very much interest in this at all in psychiatry. It was really kind of viewed almost as a negative thing. Religion in general was viewed very negatively. It's in many ways completely flipped now, because psychiatrists are writing about this, teaching about this, and incorporating it into what they do with their patients as a component of the strengths model. So it's just interesting observation about where psychiatry has been and where they are now on that. Okay, to sum up this background section then, there is an increasing interest in spirituality and how it impacts care outcomes across the health professions. We've talked mostly about medicine. This is a big issue in nursing, of course, and in other disciplines as well. Corresponding interest on the part of patients, sorry, I got a V missing there, on the part of patients and some clinicians. Growing emphasis over the last 30 years or so in health professions training programs. And then not all patients, though, want this emphasis or expect their physicians to address this. It's an important thing to remember. This is important to some patients, but not to all patients. So the trick is figuring out when to address it with who, right? We'll talk a little bit more about that. Okay, let me stop there and see if you have any questions, general comments, anything you want to push back on or react to. Thoughts? Any questions online? Are they awake? Everybody in the room here is awake. That's good. Yes, sir.
In my thoughts, it looks like evolution of this benefits, needs, requirements for, helping a patient, understanding their spirituality, their religion. In medicine is mainly from the standpoint of understanding that from the viewpoint of how will this affect really my ability to, provide what we think is an optimal care treatment plan for whatever we're treating them for, rather than the individual's spirituality, religious standing. And so to me, that is interesting, but more of a luxury for us as clinicians. We want to know how their spirituality might affect, how we construct a therapy plan. Sure. So it's more, I think, more of a constructual process for us.
It's a great point. I really appreciate that. And, you're right. For the clinician, the very busy clinician, this is a very practical issue in terms of how do I actually incorporate this into the care that I provide while still being efficient and still being able to see all of my patients and take care of all of them. And I think that's a wonderful point. How practical is this? Does this really play a role in your everyday care? And I think the answer is sometimes it does and sometimes it doesn't. So I'll give you a couple of examples here in just a minute. But a lot of the conversation around this is exactly on this question. Is this appropriate for physicians to do in the first place? And if we think that it is, how do we do it in an efficient way? How do we make sure that we maximize the benefit of this for our patients while at the same time respecting those who really are not interested in this? It's a delicate balance. Great point. Other comments? Okay, so then the next part of this talks about taking a spiritual history. And again, I'm very glad to hear that this is something that you all have had some exposure to. And I can tell you when I first started doing this work and working in this area, this almost never happened. It was just something that nobody ever did, nobody ever heard of. The whole idea of taking a, quote, spiritual history was and remains a little scary for a lot of clinicians because it's like, this is really not my area. I don't know anything about this, so why should I delve into this? Well, hopefully, if it's nothing more than just acknowledging the importance of this for a patient, I think that would make a difference. But let's talk a little bit more about how this works. Why is it challenging to discuss or explore these issues with patients? Well, there's probably any number of reasons. Some would say it's none of my business. It's really not part of what medicine should be. This is something better left to the chaplains or other professionals who have had more training on this, and it's probably something that I don't need to delve into. It's not relative to providing health care. I think it's a little bit more difficult to hold that position, particularly if you talk about certain situations like emergent care, end-of-life care, etc. It is relative, at least in some situations, I think. I'm not a religious person myself, so therefore I'm not going to do this. Well, that's certainly a legitimate position to take. However, I will tell you that I have talked with many clinicians over the years who have said, I personally have no interest in this area. I'm not a spiritual person, I'm not a religious person at all. But if it's important to my patients, I'm going to at least acknowledge that and listen to them and support them if I can. So they would probably say, even though I'm not a religious person, it's not about me or what I think or believe, it's about the patient. So that emphasis on the patients, is what drives a lot of this. It would take too much time. Certainly that's a serious concern in terms of how busy you folks tend to be and whether you could really take the time to do this. I think in certain situations you may have more of an opportunity to do it than others. That's what chaplains are for. That's fine. Chaplains are the professionals. They're very good at this. I would really love to see our chaplains more and more integrated into the care teams. I think they often are, but sometimes I think they would tell you that they often feel like they're not thoroughly integrated into the care process where they could be. I don't know enough to meaningfully discuss it. It's certainly a good position to take, certainly one that you can change by learning a little bit more about it. And then finally, you'll find some clinicians who are very comfortable with this and say, it's not a challenge for me at all. I'm very comfortable doing it. So I don't know if any of y'all have met or seen this done by an attending or by an upper level resident or fellow But it's interesting to see how that's happened. I think back on my own experience. I think every primary care provider I've ever had, as part of the workup for as a new patient, I have almost always been asked about this. And I think that's really cool. They bring it up generally as part of the social history, and they ask questions, and we talk about it, and then we move on. They make note of it in the chart, and that's good. So I'm very happy that that has happened in my experience, and I imagine that it happens with lots of other folks too. So this has been studied. There have been a number of studies about physician views on the top 5 barriers to addressing patient spiritual needs. Lack of time pretty consistently comes out first. Yes?
Just about the last slide.
Okay, let me see if I can go back. Yep.
Yeah, another challenge that I've come across is when you're so obvious in your religion, in your appearance,
Okay.
it makes patients a little bit hesitant to be more vocal about theirs.
I see.
And it can be even like, for me, it's Islam. So I have seen like Muslim patients being less inclined to be open towards me because it comes under that, are you more religious or are you less religious?
Right.
And it's even harder for me to talk about these things. So I've noticed in like heads exams for kids, they're not honest about whatever it is.
Wow.
So
Yeah, that's a wonderful point that I hadn't thought about.
What they're going to say, or are you
exactly, or
going to be
they
judging?
have that, exactly, they have the assumption that maybe I'm judgmental.
I see. Okay. Yeah, that's a wonderful point. That hadn't really occurred to me. That's really good. The concern might be, I'm different than you, we're different, and so maybe we don't have much to talk about in this regard, or maybe it's hard for me to talk to you because you're obviously religious and I'm not.
Yeah, exactly. Or I actually told my attending that maybe it's better if you take the people from my culture and do their heads, because I know that they're not gonna be comfortable telling me, which is weird because you'd expect the opposite. But
Yeah, no, that's a great point. Thank you for bringing that up. It also has to do with the fact that sometimes patients will want to request a clinician who they feel is similar in terms of their beliefs.
that's true. Yeah, that can also happen.
So that happens sometimes in a more positive way. Maybe that's a good thing if that happens. But it's also a bit controversial, I guess you can imagine, because do patients, sometimes it's possible to meet that kind of expectation, and sometimes it's not. You may be the only subspecialist available for this patient's needs, and if they're not comfortable with you for whatever reason, then you have to work through that. So that's a great point. Thank you. Okay, so probably the biggest expression of a barrier to doing this by physicians over the years very consistently has been lack of time. So this goes back to practice patterns and efficiency and when to do this versus when it's not really appropriate to do it. And even if there's time, how do you do it? But a lot of times the time pressures are very real. And I think that's showed up pretty consistently. Another idea is the lack of training, which we mentioned before. Uncertainty about how to identify patients with spiritual needs. How do you know which ones have these needs or have this interest in speaking with you about this? Concern about projecting one's own beliefs onto patients is very real, and we have to think about that very carefully. And then finally, uncertainty about how to manage patients' spiritual issues. So this came out of a study in 1999, a little bit dated, but there have been numerous studies that have had very, very similar findings. So this is an issue in terms of how do we get through these barriers. So when do we talk about this? When is it appropriate to bring this up? Well, there's no real consensus on this, I don't think. There's a real range of opinion. Some clinicians would say only in very well-defined certain situations, and you can probably imagine what those are. End-of-life care, emergency type situations. Those things, those situations are so full of emotion and so full of import that it has to come up almost in those situations. Now, again, that doesn't mean the physician has to do it. You can often involve a chaplain or somebody else. But it's in those types of situations where I think this is probably the most prominent and the most important. I think the key concept here is to focus on the patient and to respond to any cues that you might see from the patient. We talked a little bit with those scenarios about cues. Yes, ma'am?
How do you involve the chaplain? Because sometimes the family will say no directly, very adamantly. Do you not ask the family and directly send the chaplain in, or how do you offer the chaplain in a more...
Yeah, I think all you can do is make it available and say, we have chaplain services available, and maybe describe a little bit about what they do, and then if they say no, then you have to respect that, right? I think a lot of times, though, it doesn't occur, maybe often enough, to involve the chaplain in the first place. Some people also may have a preference, like instead of interacting with a hospital chaplain, they may say to you politely, no, I don't really want to talk to the chaplain because I have Dr. or I have Mr., referring to somebody in their faith community that will come by and speak with them about these things. So you can always encourage that as well. Does that make sense?
Sometimes too, when you say chaplain, they think one religion.
Yeah.
And our services at Carilion includes a lot of different, but they don't know that, especially if you don't say that. So they think you're trying to point them in one direction. And they really, the chaplaincy, they came and gave a talk as well. And
Oh, good.
they pulled from, they really are trying to connect people to lots of different spiritualities and backgrounds. So, but I don't know if we're always great at saying that up front, and maybe they're just assuming you mean one thing.
Yeah, that's a wonderful point. So sometimes people have sort of a preconceived notion of what a chaplain is or what they do. And chaplains are trained specifically not to come into their role with any particular religious point of view, rather to react in a very general sense and support patients of all different types of points of view. That's an inherent part of their training. I know that because I've been on the advisory board that oversees the chaplaincy program here for a while. And so that's very, very important to them. So they're not going to come in with some type of axe to grind or some type of perspective to impose upon a patient. They're there to listen, to respond, to support them, whatever their belief system is. Yeah. Great question. I hope we helped. So again, we're talking about responding to patient cues. And the art of this involved, I think, is to, again, as we mentioned, to figure out which patients do and do not want you to inquire about this very personal area. So that's the trick to it. And there's no pat answer to that. I really believe strongly that it probably should be addressed as part of new patient, sort of routine introduction, getting to know your new patient for the first time, taking that comprehensive history and doing that comprehensive physical. I think it's natural to bring it up there. Then I think you react to the cues or the inquiries of patients in this regard. There are some clinicians who are a little more assertive, who feel like, for example, they want to maybe be a little more assertive in terms of bringing this up themselves. A common question that I hear a lot, and you may have run into, is what do I do if a patient asks me to pray with them? Does that ever come up? Anybody ever run into that? You mind if I put you on the spot? What did you do?
I prayed with them.
Good, good. Yeah, it's a very tricky question, right? Because what if you're a person that really doesn't have that belief system? What do you do? Or what if you are? Or what if your faith system is different from theirs? Again, I remember one of the first times this came up, a third-year medical student was on the psychiatry rotation at the University of Kentucky. And the attending tells the story. It was a little funny at the time, but maybe not so, I don't know. But the student was in the room, the inpatient room with the patient, and the patient said, would you pray with me? And the student got up and left and ran out of the room to grab the attending and said, what do I do? What do I do? Very legitimate response, right? But the attending says, well, probably getting up and running out of the room when they asked the question was not the best approach. But let's go back in there together and we'll figure it out. You have some clinicians who more prospectively offer to pray with their patients. I know we have some folks here before surgery who will offer, would you like me to pray with you before we go into surgery? Again, I'm not making a judgment call. I think there's room in there for your preference as a clinician to do that if you want. You also have to be prepared for the fact that not every patient will want that. Not every patient will react well to that. People that do that typically will say most patients react well to it, even if they're not particularly religious. They're like, sure. So this is tricky, and it's a personal, you have to figure it out on your own. I think most clinicians would say, even if I'm not a spiritual person, I can at least say to the patient, well, that's not something I really do very often, but I'm happy to stand here and close my eyes and be with you while you pray. Or something along those lines. That way you're being supportive as best you can. So, very tricky. I think the last bullet point is important. The nature of the relationship is the key. I know my primary care provider very, very well. Love him, great provider. Would not hesitate to talk to him about anything. But if for some reason he quit practicing medicine and I had to get another primary care provider, I wouldn't feel as comfortable, right? Why? Because I don't have that as good a relationship. I have to develop that over time. I think that really enters into this. In general, the more you trust your provider, the closer you are, the more you have interacted with that clinician. Sorry, I'm trying to eliminate the word provider from my vocabulary. I don't like that word. It still slips in there. I like to use the word clinician. The closer you are, the better the relationship, the more likely it is that this will be something that will be perhaps easier to do. So again, how and when should this be done? With new patients, we talked about certainly during crisis-oriented circumstances, end-of-life care, when the patient initiates it as part of the strengths model, or when this idea of spiritual pain or distress is present. Here's another example. A 28-year-old female recently divorced. She finds out through the grapevine that her ex-husband may have had AIDS. She comes in as a walk-in patient to be tested for HIV, which turns out to be positive. She is very religious and believes that being HIV positive is her, quote, punishment from God. I throw that out there just as something for you to think about. I don't have the definitive answer about how you would or should react to that. But it's an example of a cue where perhaps a person's spiritual or religious beliefs are a very important part of how they think. Okay. There are some methods in the literature that talk about how to take a spiritual history. One is called FICA. No, that has nothing to do with Social Security. It's faith, importance, community, and address. How do you want me to address it? And you can read through those bullet points there. That's one of the more prominent models that people use. There's another one called the HOPE method, which again, these are just ways that you kind of organize your approach to this. Here's some possible questions to ask patients if it seems appropriate, or if they have cued this, or if they've said to you, this is something that's very important to me. What are your hopes or fears or expectations for the future? How are you coping with your illness? Is a good one. Are your spiritual beliefs a help or a source of stress for you during this time? How would you like me to address these issues in your care? You may have seen this done either well or not so well. So just would ask you to think about that. Here's another example. For many people, spirituality is an important strength. I'm wondering if you would be interested in exploring how spiritual strengths might be used to address some of the problems you've mentioned. That's a little bit more of a commitment, that kind of statement, right? That implies that you're really going to have more of a conversation in depth about that. So that may or may not be appropriate to every situation. And then finally, there's the boundary issue. We all know that the relationship between the clinician, the physician, and the patient is sacred, has to be safeguarded. There's a certain amount of vulnerability when patients are being cared for a healthcare professional. There's a power inequity there, and so most people will say that you should never try to convert a patient to your particular religious or spiritual beliefs. This is generally considered unethical and unprofessional. It's okay to honestly answer their questions about your beliefs. Have you ever had a patient ask you, Doc, do you believe in God? You have to think about what your answer will be. But you have to answer that in a way that doesn't put any undue pressure on them to believe what you believe. That makes sense? Okay. And you also must respect religious or cultural spiritual differences. So in summary, taking the spiritual history, it has to be about the patient. There's typically a high level of interest in this subject on the part of at least some patients, if not many patients. The role of clinicians or other caregivers is important in addressing these concerns. How and when to address them is critically important. Any comments, questions, pushback? Okay. Finally, the last part, the impact of spirituality on health outcomes. So I'll give you a caveat here right from the beginning. People do seminars on this that could last 2 or 3 days. I mean, this area of inquiry and research has exploded over the last 30 years, so we're just going to be able to hit the high points here. I'm going to make some very general, broad statements that are supported in the literature, but I haven't done a deep dive on this recently. So this is my part 2 video. If you want me to come back, I'll do the work, and we'll come back and we'll have a whole session just on this. We could probably focus it on pediatric-related conditions. But if you look at this and you say to yourself, what if someone as a clinician offered you an intervention that would increase life expectancy, help patients cope with their illness more effectively, and improve their ability to recover from illness? If somebody offered you that as a clinician, would you be interested? You probably would. Some people would say that's what this is, that in fact spirituality or religious beliefs has that impact on folks. I'm giving you a list here on 2 slides of some of the clinical conditions that have been examined in terms of what role, if any, does spirituality or religious faith play on outcomes for these types of conditions. I will tell you that the great majority of this literature focuses on religion as opposed to spirituality. Now, why would that be the case? Because religion is behavioral. You can observe people's behavior, or you can ask them to tell you about their religious behavior. Do you attend a meeting with people of your same belief system? Do you read sacred literature? Do you do the following? That's all behavioral. Behaviors can be observed. Spirituality is a little harder to observe. So that's why the great majority of the literature focuses on religious behavior. Here's more conditions. This is just a partial list. There's one real place that really has established themselves, and that's at Duke. I mentioned Dr. Koenig. He is associated with what they call the Center for Spirituality, Theology, and Health. They put out a very nice monthly newsletter called Crossroads, and it's a summary of the research literature. Once a month, it'll come to your inbox. It'll be about 4 or 5 pages. It's a PDF file, typically. It'll have little paragraphs about different studies on different aspects of this, along with a little commentary by the editor, usually very brief, very easy to read through. So if you're interested, you can go to this link, sign up for it, and they'll send it to you every month. And it's really a nice way to stay in touch with the literature. Prominent researchers, if you want to delve into this, Harold Koenig at Duke, Kim Pargament, who is Professor Emeritus at Bowling Green State University, and then Tyler Vanderweel at Harvard. I would add one name to this, a gentleman named Farr Curlin, C-U-R-L-I-N. Forgot to type his name in here, but he is an internist, was in Chicago for a while, is now also at Duke. And Dr. Carilion has done a great amount of research in this area as well. A lot of the research focuses on coping skills and this idea of psychoneuroimmunology. So what is the connection between health or illness outcomes and such things as stress or anxiety, forgiveness, hope, those sorts of things. In other words, what role does the mind and one's attitude play in immune system functioning? That's what psychoneuroimmunology is about. And a lot of the research in this field reflects that particular approach. Here's a quote from 2001. The research literature on spirituality and health in nursing, medicine, and other disciplines has grown dramatically in the last 20 to 30 years. Certainly true, continues to be true. And this was from a study that looked at studies between 1990 and 1999, so it's a bit dated. But at that point in time, 17% of all research studies published in oncology journals and 10% of all mental health psychology journals during that time period included some aspect of religiosity or spirituality. That percentage may or may not be a bit higher now, but it remains a very, very prominent issue in research. I'm going to give you some very, almost like assertion type statements, just to think about, just to whet your appetite for more. So maybe if I come back and do part 2, then we can talk about this in more detail. Patients with strong faith have better health outcomes when they're physically ill. That's a very pejorative, assertive, general statement. Some people would say that's true, some people would say it wouldn't, but it's out there in the literature. People who attend religious services have lower IL-6 levels, which means a possibly better immune response. People who attend religious services regularly read holy literature and pray often have lower diastolic blood pressure and are hospitalized less often. Is that the case in every case? No. But there's evidence for these statements out there. People with strong religious faith are less likely to suffer depression and recover more quickly. That's out there. I'm not saying it's true or not. I'm simply throwing it out there to get you to think about it. There's been a number of studies on mortality, and this is pretty solid. People who have regular spiritual practices tend to live longer. Been a number of major longitudinal studies that have shown that. Coping. Patients who are spiritual utilize their beliefs in coping with illness, pain, and life stresses. It's probably pretty obvious. And recovery, spiritual commitment tends to enhance recovery from illness and surgery. Hundreds of studies have examined this relationship between illness states and various types of spiritual or religious coping mechanisms. Results are mostly positive in terms of the impact. Not always so, but mostly positive. And it doesn't really seem to matter which particular faith system is held by the patient. So in my elective that I offer to medical students, I offer them a smorgasbord of articles to choose from in terms of you can read about this issue from this particular faith perspective, or that issue from that faith perspective, or, there's a whole range of things in there. And it really doesn't seem to matter which particular faith system is the patient holds. If they have that faith system, it can have a positive impact on their health. Okay, I know that's a very high level sort of general summary of the research literature. You could poke holes in probably everything I said there, but we could come back and look at that in more detail at some other time. So to kind of wrap this up, and then we'll have some questions. Patients want their physicians or other clinicians to address their spiritual concerns. Probably should say some patients want that. Not every patient, but some patients typically do. Again, important geographic or regional differences. Patients' belief systems may have a positive or a negative impact on health outcomes. The majority of research seems to indicate that it is more positive. However, one must approach this very cautiously and with respect for those, in general, for those who do or do not have these types of beliefs, certainly respecting those whose beliefs may differ from your own. Again, it's about the patient. It's not about what you believe or don't believe. It's about what they believe and how that can be helpful to them in terms of coping with their illness. And then there's the power differential between, sorry, I didn't look at my slides very closely, the clinician and the patient is important and must be respected in all circumstances. So do you agree or disagree with this statement? Insofar as religion is one of the most prevalent and powerful ways in which people find meaning and value in their experience, including illness, we physicians would be foolish to ignore the diverse resources for faith that are available to and being used by our patients. It's a rhetorical question, you don't have to answer, but something to think about. That may be my last slide. Yep. I want to acknowledge Dr. Tom Milam. Anybody know Dr. Milam? Some of you may know him. He's a psychiatrist and also I think he's a priest in the Jesuit tradition. So he's had theological as well as medical training. And he's a practicing psychiatrist, teaches in our curriculum, has an appointment in our school, but now is working primarily in the area of telemedicine for psychiatry. I borrowed from Tom's slides to put some of this together. He's aware of this, but I really want to acknowledge him and thank him. He's very thoughtful and has done a lot of work in this regard. There's my email if you want to follow up in any way. Be happy to correspond with you. And at this point, I'd love to answer any questions that anybody might have or listen to comments or push back or whatever.
What does the literature show with, in terms of patients and physicians being of the same spiritual or religious background in terms of compliance and outcomes?
Is there a relationship between health outcomes and sort of holding the same spiritual beliefs in common? Is that a good way to? I don't know the answer to that. It's a fascinating question. I bet there's probably somebody that's looked at it. But
I mean, I know they've looked at, in terms of racial and ethnic concordance, and there are very positive things in terms of not just satisfaction for the patient, but actual outcomes later on. So I just wondered if it went to that.
yeah, that's a great question. I don't know the answer. I'll look into that. That's raises some questions in your mind about, okay, if that, let's say that turned out to be true, that if I have a particular illness and I'm working with a physician who's caring for me and we share the same spiritual beliefs, am I going to do better than I would have done if I were being cared for by somebody who did not have the same spiritual beliefs? I don't know, but let's just say for a second that that's true. What would be the implications of that? I don't know. Maybe similar to like the implications in other areas. Like we used to do, I don't know if we still do this with our third-year medical students or not, you guys would know, but we used to have a session where we would throw some learning environment sort of issues at you and ask you to react to them in a small group. And one of them had to do with patients who are from the same ethnic category. So let's say you were in clinic and you are a white clinician and a black patient comes in and says, I don't want to see you, I want to see a physician who is black. How do you handle that? And we kick that around, and people have different opinions, and you could sort of make an argument in two directions. You could say, well, if it's better for the patient, they're going to be more comfortable, great. But you could also say, it may not be a luxury that we have. So what we have is what we have. So I don't know what the clear answer to that is, but it reminds me of that. It's a similar kind of thing, right?
As a follow-up question to that, is there any evidence that accommodating or asking about the spiritual or religious beliefs of the patient and trying to make the best for that improves the recovery for them?
I want to say yes. There are a number of studies that have looked at that, and it is very specific to particular conditions, but I can't cite you a study in that respect. But it's been looked at a lot. I don't know if you're familiar with this, but anybody heard of the famous intercessory prayer studies or the infamous intercessory prayer studies? So this has been done probably a couple of dozen times in different locations with mixed results. But 2 or 3 of the first studies, there were double-blind, randomized, controlled trial studies where you had 2 groups of patients who were both undergoing cabbage procedures. And one group was prayed for by strangers who were not in the same place that the patients were. They were scattered all over the world. They were told simply a person's first name and said, pray for this person for the next 2 weeks. And during that 2 weeks of time, the patient was undergoing the procedure. The other group was not prayed for, right? What do you think happened? People in the prayer group had better outcomes across the board. Now, one could look at that and say, well, that's kind of flawed study. For one thing, how do you know that the people who were not being prayed for by the official prayers were being prayed for by somebody else? Of course, you don't know that. So both groups of patients could have been the beneficiary of prayer of some kind. So that's a big hole in that study. But if you just Google intercessory prayer studies, you'll find all kinds of fascinating things along these lines. So it comes to mind when you ask the question, do we know that this makes a difference? I think some people would say, yes, we do know that, but it's under certain very carefully controlled conditions. And the other thing with a lot of these studies, as I mentioned, is they focus on religious behavior. So you could have an intervening variable, right? To simply say somebody is healthier because they attend church services once a week. What does that mean? What is it that actually increases their health?
Well, it also has to do with community. It has to do with a lot of other factors. But I guess my question was more directed towards hospital and caregivers within our facilities caring about the patient's spiritual beliefs and us asking about their beliefs and trying to facilitate spiritual care for them.
Sure.
Whether that has proven to improve their care and their recovery.
Sure. I think there are probably some studies that would indicate that that is true.
Okay.
But I just can't cite them for you right now.
Okay, that's okay.
I'm whetting your appetite for part 2. These are great questions, and I would love to come back and talk about them in more detail. Because it's very interesting, the questions you're asking. And we need to subject this to the same sort of evidence that we look at with a lot of things, right? Somebody wrote an article facetiously a few years back that said, should physicians prescribe prayer for their patients? And they wrote that on the basis of reading some of these studies that apparently showed some positive impact on prayer. And so the question was sort of rhetorical, sort of in some ways not serious, but in other ways serious, you know. If this is really true, then should physicians be very assertive and say, listen, one thing that would really improve your health is if you started praying. I don't know about that, but it's interesting to think about. Yes, sir.
You mentioned the patient who says, I don't want any of your medicine.
Yeah.
My God will take care of my issue.
Right.
How do you know, if we're trying to be spiritually sensitive to our patients,
Yeah.
how do you view trying to convince them otherwise to accept the medication or your therapeutic approach?
Yeah, that's a great question. I think generally speaking, folks would say, if you're really taking the patient-centered approach, and if they really say to you, I'm not interested in this, then you have to kind of respect that. That doesn't mean you cannot do anything. You know, you can still suggest, well, for example, if somebody said that to you, you can say, well, you know, if you change your mind, I'm happy to talk to you about this at some future time. Or you could say, well, just in case you might be interested, we have some great chaplains that would be happy to come by and speak with you. You know, those sorts of things that would express a supportive stance for the patient without sort of being too, you know, pushy about it. Does that make sense?
It does, but there are some that would argue that that's counter to the Hippocratic Oath.
Really? Yeah.
Well, especially in pediatrics, when suppose the parents take that view and it borders on neglect in terms of taking care of the child's diagnosis. So where is that? It's sort of a big ethical dilemma.
So if you had parents who were not taking care of their children, and one of the primary reasons was my religious beliefs,
my spiritual beliefs on.
It's a little different in the case of children. I mean, we do a lot of bioethics cases around children and when to intervene, and there's a pretty well established ethical principle of beneficence which says you got to do good. And if you have a child who is not capable of independent thought or process, and you know, you have the whole discussion about when is that. You know, if you're talking about a teenager, that's one thing. If you're talking about a 5-year-old, that's different. It's a very young child who obviously doesn't have decisional capacity, and there's something going on that you feel like they're being neglected. You have to intervene over the wishes of the parents, and that happens sometimes. People will say there are certain religious communities who, for example, do not believe in healthcare, or believe it only in a very minimalist way, and they'll say no. And of course, the most common example of this, of course, is the blood transfusion issue, where parents will say no. Don't believe in that, I'm not going to have that. It's very well established that the courts will intervene in those kind of situations.
Along those lines, something that's I've seen more recently and is very challenging to deal with is in realms of sexuality and identity.
Mm-hmm.
And then, you know, in our teenage population, and you've just had this really in-depth conversation with this teenager, and then the parents will, not in front of the parent, and the parents will when they'll just tell you, but no, they can't be that. They can't. We are this background.
Right.
We are this religion.
This is against our belief system.
Yes. And it creates these, really horrible situations where there's significant mental health issues that are not being addressed. So.
I agree with you. That's about as tough a situation as I can think of. And I know any of you having to sort through all that, I really don't. It's interesting because the evidence on that whole area is evolving, as you know. People have all kinds of different opinions about it. Again, probably a lot of variation from state to state, region to region, whatever, but now you have a lot of states who are actually passing legislation and so forth. So it really puts like pediatricians in the bind if, you know, what you feel like is the best care for this child or this adolescent is at variance with the law in the state where you're practicing, right? I mean, what do you do? It's a tough spot. Yeah. I'm just here to make you think. I don't really have too many answers.
No, you can't give us the answers, David.
Oh, really? I'll sit back. I'll think about it. If you want answers, I have to have more time.
Come back.
Well, thank you very much. I hope this at least stimulated some thought and reflection and